Welcome to the Deep Dive. Today, we are tackling, well, a really huge task. We've got this stack of high-level clinical guidance on cardiovascular management.
Quite the pile.
It really is. We're talking protocols for everything,
Yeah.
from routine screening right through to those first critical minutes in an emergency.
That's right. And look, if you're looking for maybe a comprehensive shortcut to getting properly informed on modern cardiology, this is probably it. We're going to try and structure these complex guidelines into clear, actionable steps.
Yeah.
This isn't just, a list of conditions. It's more like the blueprint for how doctors manage everything: acute emergencies, chronic structural issues, those tricky rhythm disorders, and crucially, the prevention strategies that are, well, the bedrock of heart health.
Our goal here is to cut through all the jargon, give you the core principles, those really critical if this then that decision points, and maybe some surprising details that define cardiac care right now.
Exactly.
We want you to understand not just what the protocol says, but why that specific step follows the last one.
Yeah, we'll be connecting the dots, between long-term risk assessment and those immediate treatment decisions. We're essentially translating the language of the clinic, maybe the emergency room too, into practical knowledge you can hopefully grasp and remember.
Okay, let's start at the beginning, the foundation. Before anyone gets sick, prevention is obviously key.
Absolutely.
And prevention really starts with numbers, right? Knowing the risk.
Yeah.
This is where that QRS tool comes in. Who gets screened and when.
Right. So we start screening otherwise healthy people with QRS from age 40, and then we repeat that assessment every 5 years.
Every 5 years, yeah.
This tool, it calculates a person's 10-year risk of having their first major cardiovascular event, like a heart attack or a stroke. It's designed to be really proactive.
And what's the magic number? That critical threshold where the approach shifts from just lifestyle advice to actual medication.
That threshold is 10%. So if the calculated risk comes out less than 10%, the main recommendation is, look, rigorous lifestyle changes, diet, exercise, definitely stopping smoking.
Right.
But if that 10-year risk is 10% or higher, then intervention is formally offered. And specifically, that means starting statin therapy.
I think it's worth just pausing on that 10%. What does that actually mean to the patient sitting there?
Yeah, it's a really important distinction. Someone hearing they have, say, a 12% risk might think, oh, that sounds low. But clinically, it means over the next decade, 12 out of every 100 people just like them are likely to have a serious event.
Wow.
And that absolute risk is definitely high enough to warrant medication because we know statins can significantly reduce that risk.
Now, the sources mentioned something important for efficiency, certain groups where you actually skip the QRS assessment altogether because their risk is just assumed to be high. Who are they?
Yes, that's a critical list to know. So if someone already has established cardiovascular disease, meaning they've previously had a heart attack, a TIA, stroke, angina, or peripheral vascular disease,
Yeah.
PVD, their risk is already high. No need to calculate.
Makes sense.
You also bypass the score if they have type 1 diabetes,
Yeah.
particularly if they're over 40 or have complications. Then there's chronic kidney disease, CKD, certain genetic conditions like familial hypercholesterolemia, or even just being over 85 years old. For these groups, the management pathway is pretty much set.
Okay, let's talk statins then. They're central to prevention. But there's a big difference in dosing, isn't there?
Right.
Primary prevention versus secondary? Why the different intensity?
It really reflects the level of threat. For primary prevention, that's someone who hasn't had an event yet but has that high QRISCA score. We typically prefer a atorvastatin 20 milligrams. It works well, generally tolerated.
Okay.
And for this group, the sources are very specific. Things like aspirin, fibrates, omega-3 supplements. They are not recommended for primary prevention anymore.
But if they have had an event-established CVD, that's secondary prevention, and the game changes.
Absolutely. The arteries are known to be diseased, potentially unstable. So for secondary prevention, we go straight to the high-intensity dose, atorvastatin 80 milligrams.
80 milligrams, big jump.
It is. And this aggressive dose, it does more than just lower cholesterol levels. It actually works quite quickly to stabilize existing plaques in the arteries, making them less likely to rupture and cause another acute event.
And how do we know it's working? What's the monitoring target?
We check their non-HDL cholesterol levels after 3 months. Now, the target isn't a specific number on the scale, it's about the change. We need to see at least a 40% reduction from their baseline non-HDL cholesterol.
Ah, okay. A relative drop.
Exactly. It ensures the statin is having a real effect, whatever their starting point was. And if we don't hit that 40% mark, we'd usually look at increasing the statin dose or maybe adding another drug like ezetimibe.
Before starting, though, safety first. What are the absolute no-goes, the main contraindications for statins?
Safety is crucial. So, four main ones to remember. Statins are avoided if the patient has active liver disease, or if their liver enzyme tests, specifically the ALT, are more than 3 times the upper limit of normal that suggests the liver's under stress.
Right.
And really importantly, they're contraindicated in pregnancy and during breastfeeding because of potential harm to the baby.
Okay, got it. Now let's pivot to the other big foundational issue. Hypertension. High blood pressure. Often called the silent killer because it's usually asymptomatic, isn't it?
That's exactly right. But silently, it's damaging blood vessels, the heart, kidneys, eyes.
So what clinical signs are we actually looking for that tell us the pressure's been high for too long, this end organ damage?
Yeah, we're looking for evidence of that damage. So in the eyes, we look for retinopathy, changes to the small blood vessels at the back of the eye. For the kidneys, we might check urine for protein or blood. And for the heart, often an ECG looking for left ventricular hypertrophy, LVH. That's the heart muscle thickening up because it's working too hard against high pressure.
And actually diagnosing hypertension is quite specific too, accounting for that white coat effect.
Precisely. A single high reading in the clinic, say 140/90 or more, that's just a flag. It doesn't confirm the diagnosis on its own.
We really need to confirm it, ideally using ambulatory blood pressure monitoring, ABPM, where you wear a cuff for 24 hours, or home blood pressure monitoring, HBPM.
And the diagnostic threshold for those average readings is actually lower, 135/85 or above.
Yeah.
That helps filter out clinic anxiety.
Okay, and just quickly, before we hit the treatment steps, can you define the stages?
Sure. Stage 1 is a clinic reading over 161/90, or that ABPM, HBPM average over 135/85. Stage 2 is more serious, clinic over 160/100, or average over 150/100.
Right.
And then anything where the systolic, the top number is 180 or higher, or the diastolic, the bottom number is 120 or higher, that's classed as severe hypertension. Needs managing pretty quickly.
Right. Now, for the famous stepladder for treatment, this is a really structured algorithm, isn't it? And it seems to hinge on just two things, age and ethnicity or diabetes status.
It is highly structured, very efficient. We use this A as C, D mnemonic. A is for ACE inhibitor or an ARB. C is for calcium channel blocker. And D is for a thiazide-like diuretic. So step 1 is the initial choice. And this recognizes that, well, the underlying cause of hypertension can differ between groups. Older patients, so 55 or over, and people of Black, African, or Caribbean descent often have lower levels of renin in their blood. This means their blood pressure isn't as driven by that renin-angiotensin system. So they tend to respond better initially to a calcium channel blocker that's C.
So over 55 or Black ethnicity start with C.
Got it. Correct. But if the patient is under 55 and doesn't have Black ethnicity, or if they have type 2 diabetes, irrespective of age, we start with A, the ACE inhibitor, or ARB. These groups tend to have higher renin activity, so blocking that system works better initially, and it also offers some kidney protection, especially in diabetes.
Okay, that makes sense. So if that first drug, even at its max dose, isn't enough, we go to step 2, dual therapy.
Yep, combine effective classes. If you started on A, you add C or D. If you start on C, you add A or D.
So A plus C is common.
Very common. ACE inhibitor plus a calcium channel blocker. But the key is you try the first drug, push the dose up, give it maybe 4 weeks, then add the second if needed. Give each drug a chance.
In step 3, that's triple therapy.
That's the maximum standard combination. A plus C plus D. So an ACDI or ARB plus a calcium channel blocker plus a thiazide-like diuretic. If the blood pressure still isn't controlled on all 3 of those, we call it resistant hypertension.
Which brings us to step 4. And this is where it gets really elegant based on a simple blood test.
Yeah, it's the potassium check. It's all about managing the risk of messing up their potassium levels, especially since they're already on A and D, which can affect potassium.
How does that work?
Okay, so you check their potassium, their call level. If it's on the high side, say above 4.5, you add a beta blocker as the 4th drug. But if the potassium is low, below 4.5, you add spironolactone instead.
Ah, spironolactone. That's an MRA, right? Potassium sparing.
Exactly. It's a mineralocorticoid receptor antagonist, and it holds on to potassium. So by adding it when potassium is low, you get extra blood pressure lowering, and you help correct the low potassium caused by the diuretic. It's a really neat balanced choice.
That is clever. Turning a simple electrolyte level into a guide for safer prescribing. Fantastic. Okay, shifting gears now from chronic management to, well, immediate danger, chest pain. When does it stop being wait and see and become a definite 999 emergency call?
The key things are urgency and timing. If someone has acute chest pain right now, that's an emergency. Or if they had pain within the last 12 hours and it was associated with ECG changes, that's also an emergency call.
And if you're out in the community, no ECG.
If the pain is acute, happening now, you have to assume the worst and make the call. Default to emergency.
Okay. Once help arrives, or in the ED, what's that standardized immediate management? Like the first things that happen?
Yeah, there's a pretty standard initial protocol, often thought of as the first steps for a suspected acute coronary syndrome. First, sit the patient up, make them comfortable. Second, give sublingual GTN, that spray under the tongue.
Right.
Third, oxygen, but only if their oxygen saturation, the SpO, is below 94%. We don't give it routinely anymore.
Oh, interesting.
And fourth, and this is really critical for stopping clots getting worse, 300 milligrams of aspirin, chewed or dispersed in water, as long as there's no contraindication like active bleeding or a known allergy.
Okay, MONA-ish, but with caveats on the O. Now, one fascinating skill is using the way the pain feels to point towards the cause. What are the key descriptions we listen for?
Absolutely. The quality and location are vital clues. If the pain is sharp, like a knife, and clearly worse when they breathe in deeply or move, we call that pleuritic pain, then pulmonary embolism, a clot in the lung, shoots way up the list. If the pain is described as tearing, really severe, and radiating straight through to the back, specifically between the shoulder blades, that's the classic description for an aortic dissection. A true catastrophe where the main artery wall tears.
Scary stuff.
Definitely. And conversely, if the patient says the pain feels much better when they sit upright and lean forward, that points very strongly towards pericarditis, inflammation of the sac around the heart.
Let's stick with pericarditis for a second. That positional relief is key, and there's a specific ECG finding too.
Yes, that sharp positional pain often comes with a very characteristic ECG pattern. It's called saddle-shaped ST elevation. It tends to be widespread across many leads, not localized like in a heart attack.
Bell-shaped, okay.
While it's often caused by a virus and gets better on its own, we have to watch out for complications. Mainly pericardial effusion fluid building up in that sac around the heart.
And if that fluid builds up too much, it can squeeze the heart. Cardiac tamponade.
Exactly. That's when the fluid pressure stops the heart from filling properly. It's life-threatening, and we learn to spot it clinically using Beck's triad.
Beck's triad, right. What is that again?
It's 3 signs together. 1, low blood pressure, because the heart can't pump effectively. 2, raised jugular venous pressure, or JVP, you see the neck veins bulging because blood is backing up. And 3, muffled or distant heart sounds on listening, because the fluid is insulating the sound.
Okay. Low BP, high JVP, quiet heart sounds.
If you see Beck's triad, that heart is effectively being strangled. It needs draining immediately, a procedure called pericardiocentesis.
Right. Okay, switching gears again, but still thinking about clots. Deep vein thrombosis, DVT. Diagnosis often starts with the Wells score.
Yes, a 2-level Wells score. It uses clinical factors like recent surgery, cancer, leg swelling, tenderness to estimate the probability. If the score is 2 or more, a DVT is considered likely.
And if it's likely,
then the patient needs an urgent ultrasound scan and USS, ideally within 4 hours. If there's a delay getting the scan, we actually start anticoagulation treatment first and make sure the scan happens within 24 hours.
and if the score is low, less than 2.
If DVT is unlikely, we usually do a blood test first, the D-dimer. If the D-dimer is negative, DVT is pretty much ruled out. If it's positive, then they jump back into that urgent pathway USS within 4 hours.
Okay. And once a DVT, or maybe a related PE, is confirmed, what's the usual treatment?
It's anticoagulation. Nowadays, usually with a direct oral anticoagulant, a DOAC, like apixaban or rivaroxaban, the standard treatment duration is typically 3 months.
3 months.
But here's a really important point. If the DVT or PE was unprovoked, meaning there wasn't an obvious cause, like surgery, immobility, or injury, we need to investigate further.
Why is that?
Because an unprovoked clot can sometimes be the first sign of an underlying cancer. So the protocol is to arrange investigations, usually including a CT scan of the chest, abdomen, and pelvis, a CT CAPI, to look for hidden malignancy.
Wow, okay. Important link there. Lastly, in this acute section, abdominal aortic aneurysm, AAA. Screening is very specific here.
Extremely specific. It's a great example of targeted population screening. It's only offered to men just once in their 65th year.
Just men, just at 65. And management depends entirely on size.
Entirely on the diameter of the aneurysm found on ultrasound.
What's the critical size cutoff?
It's 5.5 centimeters. If they find an unruptured AAA and it's smaller than 5.5 centimeters, the management is generally medical. strict blood pressure control, stop smoking, regular ultrasound surveillance to monitor growth.
Okay.
But if it measures 5.5 centimeters or larger, the risk of it rupturing becomes significant enough that elective surgical repair is strongly considered.
And if it has ruptured?
A ruptured AAA presenting typically with severe abdominal or back pain, a shock, maybe a pulsating mass you can feel in the abdomen that is a massive surgical emergency, needs immediate transfer to a vascular surgery unit.
Okay, let's transition now to the sort of longer-term battles against ischemia, starting with angina. That's the chest pain from not enough blood flow to the heart muscle, usually on exertion, right?
Exactly. Stable angina typically comes on with activity, goes away with rest.
Let's talk about the immediate relief first, that sublingual GTN spray. There's a strict rule for using it.
Yes, the protocol is very clear because, well, time is muscle, potentially. GTN is a vasodilator. It relaxes blood vessels to quickly get more oxygen to the heart.
How should patients use it?
They take one spray under the tongue. If the pain hasn't been after 5 minutes, they should take a second spray. If 5 minutes after that second dose, the pain is still there, they must call 999 immediately.
The 2 sprays and call rule.
Pretty much, and
Okay.
stops people waiting too long if it's actually an evolving heart attack, not just angina.
Okay. For long-term prevention, reducing how often these attacks happen, what are the first-line medications?
We usually start with monotherapy, just one drug. The choice is typically either a beta blocker or a calcium channel blocker, CCB. For beta blockers, something like metoprolol is often preferred. Atenolol less so these days.
Right.
Now, there's a really important interaction to be aware of if you're thinking about combining these classes.
Ah, yes. You flagged this earlier with hypertension. Why can combining beta blockers and certain CCBs be risky?
It's all about potentially slowing the heart down too much. You have to know your CCBs. Some, like amlodipine, mainly work on blood vessels, but others, like diltiazem and verapamil, are rate-limiting. They directly slow the heart rate.
Okay.
So if you combine a beta blocker, which also slows the heart, with one of these rate-limiting CCBs, you risk causing severe bradycardia, a dangerously slow pulse, or even heart block, where the electrical signals get disrupted. So that specific combination is generally avoided.
Good to know. So if someone's still getting angina despite being on the best dose of their first drug, what comes next before considering procedures?
Then we move to second-line options. You could add a long-acting nitrate for sustained vasodilation. Or there are other drugs like nicorandil, ivabradine, ranolazine.
Avabradine. What does that do?
It's quite clever. It specifically slows the heart rate by acting on the sinus node without affecting blood pressure or how strongly the heart contracts. Can be useful if beta blockers aren't tolerated.
Okay. And if medications aren't enough?
Then you start looking at interventions. Things like PTCA, percutaneous transluminal coronary angioplasty, basically stenting to physically open up blocked arteries, or for more extensive disease, TABG, coronary artery bypass, grafting bypass surgery.
Okay. Moving down from the heart, let's talk peripheral arterial disease, PAD, atherosclerosis in the legs. The classic symptom is intermittent claudication.
That's the hallmark symptom, yes. Pain, usually in the calf or thigh muscles, that reliably comes on after walking a certain distance and then eases off within a few minutes of stopping and resting.
Why does it happen?
The narrowed arteries can supply enough blood when the muscles are resting, but during exercise, the demand for oxygen goes up, and the blocked arteries just can't deliver enough flow, hence the pain.
But we need to watch out for it getting worse, right? Limb-threatening ischemia.
Absolutely. That's a much more serious stage. The signs are pain even at rest, particularly at night when lying flat. Patients often find the only relief is hanging their foot over the edge of the bed using gravity to help blood trickle down. And then the really critical signs are non-healing ulcers, especially on the feet or ankles or even gangrene. That signals the tissue is dying.
How is PAD diagnosed formally?
Primarily with a simple test called the ankle brachial pressure index, or ABPI. We measure the systolic blood pressure at the ankle and compare it to the systolic pressure in the arm.
And the ratio tells you.
Yes. A normal ABPI is around 1.0. If the ratio is less than 0.9, that confirms PAD. But if it drops below 0.5, that indicates severe critical limb ischemia. Needs urgent referral to vascular surgeon.
And the management plan. For the intermittent claudication stage, what's first line?
Interestingly, the single most effective first-line treatment isn't a drug, it's a supervised exercise program.
Exercise.
Yeah.
Even though it causes pain.
Counterintuitive, isn't it? But walking to the point of pain, resting, then walking again, actually encourages the body to develop new, smaller blood vessels, collateral circulation, that bypass the blockages. The evidence for it is really strong.
Fascinating. What about meds?
Medically, it's about secondary prevention, so definitely a statin and an antiplatelet drug, usually clopidogrel rather than aspirin and PED. There's also a drug called naftoterfuryl oxalate that can sometimes help improve walking distance, but exercise remains key. And obviously, critical ischemia needs that urgent vascular referral.
We touched on this earlier, but let's just quickly summarize the core medications someone goes home on indefinitely after a heart attack, the MI Secondary Prevention Toolkit.
Right. This is absolutely crucial for long-term survival and preventing another event.
Right.
There are essentially 4 pillars. 1, an ACE inhibitor, or an ARB, taken indefinitely, helps prevent adverse changes in the heart muscle shape and function after the damage.
2.
2, a beta blocker, usually continued for at least 12 months, sometimes longer, reduces the heart's workload and oxygen demand and lowers the risk of dangerous arrhythmias.
3.
3, high-intensity statin, atorvastatin, 80 milligram indefinitely for that plaque stabilization we talked about.
And 4, the antiplatelets.
Yes, pillar 4 is the antiplatelet strategy.
Let's just clarify that antiplatelet part, because it often involves more than one drug initially, right? DDPT.
Exactly. So aspirin 75 milligram daily is usually taken for life. That's the baseline. But for the first 12 months after the MI, especially if they've had a stent put in, we need much more potent clot prevention.
So you add another one?
Yes, we add a second, more powerful antiplatelet agent on top of the aspirin. That could be prasugrel, ticagrelor, or clopidogrel. This combination is called dual antiplatelet therapy, or DAPT. It's absolutely vital for that first year to stop the stent suddenly clotting off, which can be catastrophic.
Okay, let's venture into the electrical side of things now. Atrial fibrillation, AF. Probably the most common rhythm problem we see.
By far the most common sustained arrhythmia, yes. Huge impact on healthcare.
How does it typically present? What symptoms should make you think of AF?
It's really variable.
Yeah.
Some people feel absolutely nothing. Others get palpitations, that feeling of a racing or fluttering heart. It can cause shortness of breath, fatigue, dizziness. And sometimes, worryingly, the very first sign is a stroke or a TIA caused by a clot forming in the fibrillating atrium.
And on examination.
The classic physical sign, the one you can pick up just by feeling the pulse, is that it's irregularly irregular. There's no pattern to the rhythm at all. It feels chaotic.
Okay. When it comes to managing AF, there seems to be this fundamental choice. Rate control versus rhythm control. Which one is generally preferred?
Generally speaking, for most patients, rate control is a preferred initial strategy.
Why is that?
The goal with rate control is simply to slow down how fast the ventricles are beating, usually aiming for a heart rate under about 110 beats per minute at rest. It's often easier to achieve and maintain with medications, and large studies have shown that for many patients, particularly older ones, it leads to outcomes that are just as good as trying for rhythm control, with potentially fewer side effects from complex drugs or procedures.
So just slowing it down is often enough. When do we aim for rhythm control then? Trying to get the heart back into a normal sinus rhythm.
We tend to consider rhythm control in specific situations where we think restoring that normal coordinated atrial contraction will provide a significant benefit.
Such as?
Well, if the AF is very new, say started within the last 48 hours, cardioversion might be very effective. Or if there's a clear reversible cause like a severe infection, thyroid problems, or maybe post-surgery treating the cause might restore sinus rhythm. And crucially, if the patient also has heart failure.
Why is it important in heart failure?
Because in heart failure, that extra little kick of blood that the atria give just before the ventricles contract the atrial kick can actually provide a significant boost, maybe 15–20% to the amount of blood the heart pumps out. Losing that kick in AF can make heart failure symptoms much worse, so restoring it can really help.
Okay. So for rate control, what are the main drug options?
The mainstays for monotherapy using just one drug are either a beta blocker or one of those rate-limiting calcium channel blockers we mentioned, like diltiazem or verapamil, or there's digoxin.
Digoxin, that's an older drug, isn't it?
It is, and its use in AF rate control has some nuances. It's generally reserved now for patients who have permanent AF, so not coming and going, and who are largely sedentary.
And why sedentary?
Because digoxin works partly by increasing vagal tone, which slows the heart, but when you exercise, your sympathetic nervous system kicks in, overriding the vagal effect, and digoxin becomes much less effective at controlling the rate during activity. Beta blockers and CCBs work better during exertion.
Got it. Now, arguably the most critical part of AF management isn't the rhythm itself, preventing strokes. This relies on scoring systems.
Absolutely essential. This is all about risk stratification. First, we calculate the CHA Eurovascus score. This estimates the patient's annual risk of stroke based on several factors.
What factors does it include?
C is for congestive heart failure, H for hypertension, A for age 75 or older, counts double, D for diabetes, S for prior stroke or TIA, counts double, V for vascular disease like prior MI or PAD, A for age 65, 74, and SC for sex category. Female sex counts as 1 point.
Okay, quite a list. And what score triggers anticoagulation?
Anticoagulation is recommended strongly if the score is 2 or higher. It's generally offered or considered if the score is 1 for men. For women, a score of 1 is just due to being female, so they generally need a score of 2 or more, i.e. female sex plus at least one other risk factor, before anticoagulation is offered.
Right, but anticoagulation has risks too. Bleeding. How do we assess that?
That's where the second score comes in, the Haas-Bilaz score. This helps quantify the patient's risk of major bleeding if they do start anticoagulation. It looks at things like uncontrolled hypertension, abnormal liver or renal function, prior stroke, bleeding history, labile INRs, if on warfarin, elderly over 65, and drugs or alcohol use.
And what does a high Has-B-Led score mean? Don't treat.
Not necessarily. A high score, say 3 or more, doesn't automatically mean you withhold anticoagulation because the stroke risk is often still higher than the bleeding risk. But it signals that you need to be really careful. Address any modifiable bleeding risks like getting blood pressure under control, reviewing other medications, monitor them closely, and have a very clear conversation with the patient about the risks and benefits.
And the drugs used for anticoagulation?
The direct oral anticoagulants, the DOACs like apixaban, rivaroxaban, edoxaban, dabigatran, are now generally the first-line choice. They're easier to use than warfarin, fewer interactions, no routine monitoring needed. Warfarin is usually reserved as second line or for specific situations like mechanical heart valves or severe kidney disease.
Okay. Briefly, what about atrial flutter? Related, but different.
Yes, less common than AF. It's caused by a different electrical mechanism, usually a large reentry circuit in the right atrium. The ECG is characteristic. It has that very regular sawtooth pattern of flutter waves.
And management.
It often responds less well to rate-controlled drugs than AF does. So treatment frequently involves trying to restore normal rhythm with electrical cardioversion, or, more definitively, catheter ablation to interrupt that electrical circuit. But importantly, the stroke risk is considered the same as AF, so the anticoagulation decisions using CHUE's VASC are identical.
Got it. Let's move quickly to endocarditis infection of the heart valves.
Yep.
It can be subtle, but there are some classic, almost unique physical signs.
Yes, it can be tricky to diagnose initially. Symptoms can be vague fever, chills, fatigue, aches. But because tiny infected clots, septic emboli, can break off the valve and travel in the bloodstream, they cause these characteristic peripheral signs.
Like what?
You look for petechiae, tiny little red or purple spots, often seen on the palate or inside the eyelids. Splinter hemorrhages, small reddish-brown lines under the fingernails. Osler's nodes, these are small, painful, raised red lesions, typically on the fingertips or toes. And Janeway lesions, which are similar spots but non-painful, usually on the palms of the hands or soles of the feet.
Those sound quite specific.
They are pretty specific when you see them. Diagnosis is then usually confirmed using the modified Duke criteria, which combines clinical findings, positive blood cultures identifying the bug, and evidence of valve damage or vegetation on an echocardiogram. Treatment involves long courses of high-dose intravenous antibiotics, often for 4 to 6 weeks.
Right. Okay, finally in this section, mechanical problems, cardiomyopathies and murmurs. Let's start with the 3 main types of cardiomyopathy diseases of the heart muscle itself.
Okay, broadly 3 types based on the structural change. 1, dilated cardiomyopathy, DCM. Here, the main pumping chambers, the ventricles, become enlarged, stretched out, and thin-walled. Like an overstretched elastic band, the muscle becomes weak and can't contract effectively, often caused by things like coronary artery disease, long-term alcohol abuse, infections, or sometimes it's genetic. Management basically follows the heart failure pathway.
Okay, dilated and weak. What's next?
2, hypertrophic cardiomyopathy, HCM or HOCM. This is almost the opposite. The heart muscle, particularly the wall between the ventricles, the septum, becomes abnormally thick. This thickening can obstruct blood flow out of the heart, especially during exercise. It's usually a genetic condition, autosomal dominant, and it's famously a cause of sudden cardiac death in young athletes. Management involves beta blockers or calcium channel blockers, sometimes surgery to trim the thickened muscle, myomectomy, or an ICD.
Thickened and obstructive. And the third,
3. Restrictive cardiomyopathy. This is the least common type. Here, the muscle walls become stiff and rigid, although not necessarily thickened. They lose their flexibility, so the ventricles can't relax properly to fill with blood between beats. Think of trying to fill a stiff leather bag versus a stretchy plastic one. Causes include things like amyloidosis or sarcoidosis. Management is difficult, often focused on treating the symptoms of the resulting heart failure, fluid backup.
stiff and non-compliant. Got it. To finish off structure, let's quickly classify heart murmurs. The key is timing, right? Systolic versus diastolic.
Timing is absolutely everything with murmurs. It tells you immediately whether the problem is happening when the heart is squeezing, systole, or relaxing, diastole, and that points you towards which valve is likely involved.
So systolic murmurs happening during contraction.
2 main ones to know. First, aortic stenosis. This is a classic systolic ejection murmur. The aortic valve is narrowed, so blood struggles to get ejected out. It typically sounds harsh, often loudest over the aortic area, and might radiate up to the neck. It usually starts after the first heart sound and ends before the second.
Okay, ejection through a tight valve, the other main systolic one.
Mitral regurgitation. This is a pansystolic or holosystolic murmur. The mitral valve doesn't close properly, so blood leaks backward from the ventricle into the atrium throughout the entire contraction phase. It's often described as high-pitched, blowing, and is usually loudest at the apex, the bottom tip of the heart.
Leaking back throughout systole. And diastolic murmurs, happening during filling.
Diastolic murmurs are generally less common but often more serious. Again, 2 key ones. Aortic regurgitation. This is an early diastolic murmur. The aortic valve leaks, so as soon as the ventricle starts to relax after squeezing, blood flows back in from the aorta. It's often a soft, blowing sound heard best along the left side of the sternum with the patient leaning forward.
Leaking back right at the start of diastole. And the last one.
Mitral stenosis. This is typically a mid-diastolic murmur. The mitral valve itself is narrowed stenotic, so blood flow from the atrium into the ventricle during filling is obstructed and turbulent. This creates a low-pitched rumbling sound, often heard best at the apex, usually later in the filling phase, sometimes has an opening snap just before the rumble starts.
Rumbling through a tight valve during filling. And you listen for these in specific spots on the chest.
Yes, the 4 main auscultation areas: aortic, right upper sternal border; pulmonic, left upper sternal border; tricuspid, left lower sternal border; and mitral, at the apex around the 5th intercostal space mid-clavicular line. Helps pinpoint where the murmur is loudest.
Okay, we saved heart failure until near the end, partly because it's often the final common pathway for so many of the conditions we've discussed: hypertension, valve problems, ischemia.
That's exactly right. It's where many cardiovascular roads can ultimately lead.
The presentation, the symptoms can be quite classic, sometimes really dramatic.
Yes, the symptoms really stem from 2 core problems: the heart failing as a pump, causing fatigue, low output symptoms, and fluid backing up behind the failing pump, causing congestion.
What are the classic congestion symptoms?
Orthopnoea, that's waking up breathless after lying flat for a while, needing pillows to prop yourself up. Paroxysmal nocturnal dysmenorrhea, PND, suddenly waking up gasping for air, often having to sit or stand up, and just general shortness of breath on exertion. In really acute severe failure, you can get that terrifying pink, frothy sputum fluid literally flooding the air sacs in the lungs.
And signs on examination, what do you look or listen for?
We look for signs of that fluid overload. Bibasal crepitations or crackles when listening to the lungs sounds like Velcro tearing softly. A raised JVP in the neck. Pitting edema, especially in the ankles and legs. We might feel the apex beat, the main heartbeat impulse, is shifted outwards because the heart is enlarged. And often you can hear an extra heart sound, a third heart sound, or S3 gallop, which is the sound of blood rushing into an already overfilled or stiff ventricle early in diastole.
Okay. Diagnosis leans heavily on imaging and a specific blood test: echo and NT-proBNP.
Yes, the echocardiogram is key. It assesses the heart's structure and, crucially, its function, specifically the ejection fraction, or EF. That's the percentage of blood in the left ventricle that gets pumped out with each beat.
And what EF defines heart failure?
If the EF is significantly reduced, typically below about 40%, sometimes the cutoff is 35%, we classify it as heart failure with reduced ejection fraction, or HFrEF. If the EF is normal or near normal, say above 50%, but the patient still has signs and symptoms of heart failure, that's heart failure with preserved ejection fraction,
HFpEF often related to stiffness rather than weakness.
And the blood test, NT-proBNP.
Yes, NT-proBNP is a hormone fragment released by the heart muscle cells when they're stretched or under stress. It's a very useful biomarker, particularly for ruling out heart failure if the level is low, and for gauging severity and prognosis if it's high.
And the actual levels guide the urgency of assessment.
They do. The guidelines use specific cutoffs for triage. If the NT-proBNP level is very high, say over 2,000 pgml, that patient needs to be seen by a specialist and have an echo pretty quickly, usually within 2 weeks. If the level is elevated, but more moderately between 400 and 2,000, the assessment and echo should happen within 6 weeks. If the level is below 400, heart failure is considered highly unlikely to be the primary cause of their symptoms.
Important caveat, though. Other things can raise BNP.
Yes, absolutely crucial to remember. Things like older age, over 70, chronic kidney disease, severe sepsis, even pulmonary embolism can also raise BNP levels, so you always interpret the number in the full clinical context.
Yeah, let's really focus on the management for HFrEF, the reduced ejection fraction type. This is where medications have shown the biggest impact on survival, right?
Definitely. The cornerstone of treatment for HFrEF rests on a foundation of 3 classes of drugs that are proven not just to improve symptoms, but to improve long-term survival by slowing down or reversing the harmful remodeling processes in the failing heart.
What are those 3 classes?
Okay, the big 3 are 1, an ACE inhibitor like ramipril, lisinopril, or an ARB like canasertin, valsartan. 2, a beta blocker specifically licensed for heart failure like bisoprolol, carvedilol, nebivolol. 3, an MRA, a mineralocorticoid receptor antagonist, spironolactone or eplerenone.
And how are they started?
Critically, you start the ACEI-ARB and the beta blocker one at a time, not together, because both can lower blood pressure. You start at a low dose and gradually titrate up, usually every 2 to 4 weeks, aiming for the target doses used in the clinical trials, or the maximum dose the patient can tolerate based on blood pressure, heart rate, and kidney function.
Right, slowly does it.
Once the patient is stable on reasonable doses of the ACEI-ARB and the beta blocker, you then add the MRA, again starting low and monitoring potassium and kidney function closely.
So those 3, ACE-ARB, beta blocker, MRA, are the absolute foundation for improving survival in HFrEF.
They are the pillars. Everything else builds on that foundation.
Which brings us to that really important aha moment, that clarification about probably the most famous heart failure drug of all, furosemide.
Yes, this is such a fundamental point to grasp. Furosemide and other loop diuretics like bumetanide are incredibly effective drugs for managing the symptoms of heart failure, specifically fluid overload.
How do they work?
They make the kidneys excrete large amounts of salt and water, so they rapidly reduce breathlessness, clear fluid from the lungs, get rid of ankle swelling. They make patients feel much, much better, often very quickly. They are essential for managing congestion. But, and this is the crucial bit, despite making people feel better, loop diuretics like furosemide have not been shown in large trials to improve long-term mortality and heart failure. They don't fundamentally alter the disease progression.
So they treat the symptoms, but not the underlying disease process itself.
Exactly. That's the perfect way to put it. They provide comfort and relief from congestion, but they don't tackle the adverse remodeling, the neurohormonal activation that the ACE inhibitors, beta blockers, and MRAs do. Those are the drugs that actually extend life in HFrEF.
That's a really powerful distinction. Symptom relief versus disease modification.
It really is. Of course, patients need both, but you have to ensure they're on the life-prolonging therapies, titrated up as much as possible, using the diuretics just as needed to manage their fluid status. There are other drugs, too, for specialists to consider if patients remain symptomatic, despite the big 3, like ivabradine or the ARNI class, sacubitril/valsartan, or SGLT2 inhibitors now as well.
And finally, just a word on end-stage heart failure, the prognosis.
Unfortunately, despite advances, advanced heart failure remains a very serious condition. The prognosis is often poor. Broadly speaking, there's about a 50% mortality rate within 5 years of diagnosis. For patients with advanced symptoms, NYHA Class 4, the risk of death within the next 6 to 12 months can be very high.
So management becomes much more complex.
It really requires intensive input from a multidisciplinary team, cardiologists, specialist nurses, palliative care. The focus shifts towards maximizing quality of life, ensuring therapies are tolerated, managing symptoms aggressively, and having open, honest conversations about prognosis and future care planning, including advanced directives and potentially palliative options. #Harry outro.
Well, that was quite a journey. We've covered a huge amount of ground. building this structured picture of cardiac care right from those initial prevention thresholds, like why that 10% QRSK score matters so much,
Yeah, through to spotting emergencies like Beck's triad for tamponade.
and then navigating the algorithms for chronic conditions like AFib, that rate versus rhythm decision, and the step-by-step approach to treating heart failure.
I think the main takeaway isn't just the sheer volume of information, but seeing how structured modern cardiology management really is. Whether it's deciding the next hypertension drug based on a potassium level or layering those crucial secondary prevention meds after an MI.
It's all about logical steps.
Exactly. It's a layered approach designed to make sure patients get therapies that not only ease their symptoms now, but actually tackle the underlying problems and improve their long-term outlook.
So let's leave you, our listeners, with this final thought to consider. We highlighted that crucial difference with furosemide in heart failure. Excellent for symptoms, but doesn't change mortality.
Whereas the ACE inhibitors, beta blockers, and MRAs do extend life.
So the thought is this. If a patient with severe HFrEF is only taking furosemide, yes, they might feel more comfortable, but their underlying disease isn't being optimally treated to prolong their life. Considering this distinction, what does it tell you about our clinical obligation, maybe our ethical duty, to clearly explain the difference between purely symptomatic relief and truly life-extending care to someone facing a progressive chronic illness? And how should that fundamental difference shape the priorities we set in every single treatment plan? Something to think about.